Okay, it's 1 minute past 5, so let's get started. At the very beginning, I would like to thank everyone for joining, and in particular, wish everyone a healthy and a good new year 2024. Thanks for joining for our virtual grand rounds in radiation oncology. You know the format already. It's the second year, our fourth iteration of this format. We aim to present you the latest science. We aim to this science is being presented by the top speakers and giving that information into a very interactive format. The grand round is happening every Wednesday, the first of the month, in a very short time interval, 30 minutes, 50 minutes presentation, and 15 minutes discussion thereafter. I would also like to remind you that the three first presentations have been recorded, and you can see here the topics again: prostate cancer, breast cancer, and oligometastatic disease, and the recordings are available on our meeting homepage. I'm very, very happy and honored and proud to present the next iteration, which is being supported by ESTRO, SASRO, and DEGRO, and the topic is important for many of us in the field of radiation oncology: breast cancer. Regional radiotherapy for early stage breast cancer, the meta-analysis being conducted by the Early Breast Cancer Trialist Collaborative Group. And this is a question which has been addressing us in radiation oncology for a long time, where we had several randomized controlled trials. And now we have this meta-analysis being based on 16 trials and 14,000 patients. And I'm very happy that the PI of the trial is being here with us today, Professor Carolyn Taylor. She's being a professor at the Oxford University, a clinical research fellow and an honorary consultant in Oxford, a principal investigator on the Cancer Research UK program, and obviously the PI and first author of this meta-analysis. Carolyn, many thanks for joining us. We're looking forward to presenting us the data which has been generated and also sharing some further insights and maybe interpretation of the data. Thanks for joining and happy to give the floor to you.
Great, thanks very much for that kind introduction. Now I'm just going to start by sharing my slides. Can you see them?
Yes, all perfect.
Great, thank you. So my name is Carolyn Taylor. I'm an oncologist. I work in Oxford, and I also work with patients with breast cancer and do some research. I work as part of the EBCTCG, so that stands for the Early Breast Cancer Trialist Collaborative Group Overview. And the overall lead of EBCTCG is Robert Hills, who's a professor of statistics, and I worked with him and with many other people on this large meta-analysis of women who are irradiated for regional node radiotherapy. So I'm going to present the results, the effects of lymph node radiotherapy, meta-analysis of 14,000 women in 16 randomized trials. And many of you will have heard about the EBCTCG. What we do is we get all of the data from randomized trials worldwide for particular treatment questions, and we do large meta-analyses. And it's a very big collaboration between hundreds of statisticians and trialists around the world. So what I'll present is really thanks to teamwork from many different individuals. And the meta-analysis was published in The Lancet November last year, the culmination of many years of work. And on this slide, you can see some of the authors on the paper. These are the authors who were outside Oxford. There were many of us who worked on the paper inside Oxford, but we had involvement from different people in many different trial groups. So many of you may see some colleagues or friends on this slide who were authors on the meta-analysis. And really, there's been a lot of teamwork from these individuals and from many others over many years. Now, this slide shows the randomized node comparisons, and this image was drawn by Alan Pearson, who is Orit Kaider-Pearson's son. And it's beautiful, I think, and it shows the randomized regions. So there were some trials where the randomization was internal mammary chain radiotherapy versus not. Now I'm just going to get my arrow so that it stays on. Here we go. So that's the green region versus not. And there were some trials where the randomization was radiotherapy to the axilla and to the supraclavicular fossa and to the internal mammary chain versus not. So all of those colored regions. And in all of the trials, the treatment to the breast or to the chest wall was the same in both arms, and that often included radiotherapy. And this slide shows the randomized comparisons. So there were 16 trials and about 14,000 women overall. On the top row here, you can see trials which randomized women to IMC plus axilla plus supraclav versus not. And there were 9 trials, including about 8,000 women. So that was the most common comparison. On the next row, you can see trials where the randomization was IMC radiotherapy versus not. And there were 4 trials and about 5,000 women. And on the bottom row, there were just 3 trials where the randomization was axilla or supraclav versus not. And there were 11,000 women. And you'll see that most of the trial comparisons involved IMC radiotherapy. Now, the trials fall into 2 categories, the older trials on the top and the newer trials on the bottom. And the reason we did this was that radiotherapy changed during the 1980s. All of the older trials in the meta-analysis used techniques like the ones shown on the top. So these were direct internal mammary chain fields using either cobalt beams or orthovoltage beams. Whereas the trials which started after the year 1989 used more tailored techniques. And on this slide, you can see just one example of a technique that was used in a newer trial, but there were many other different ones. And these techniques were better at avoiding the heart and the lungs, and they tended to give a more homogeneous dose to the target tissues. The other thing that you'll notice, radiation oncologists, is that modern radiotherapy is better than the radiotherapy on the bottom here. It's progressed and improved even since the year 1989. So this isn't modern radiotherapy. This is radiotherapy as it was done in the 1990s and early 2000s. And now I'm going to show you some of the results. These are the results for breast cancer recurrence, and that includes all recurrences, local recurrences, and distant recurrences. And the results from the older trials are shown on the left. So on the x-axis here, you've got years since randomization going up to 20 years, and on the y-axis, breast cancer recurrence. And the squares are women who are randomized to no regional node radiotherapy, and the circles, women randomized to regional node radiotherapy. And you'll see also that in the older trials, the curves go out to 20 years because we've got more follow-up, whereas in the newer trials, the curves only go out to 15 years. But the rate ratio up here and down here is based on the whole time period in each of them. And when we look at the effect of regional node radiotherapy on breast cancer recurrence, there's no evidence of any effect in the older trials. Those curves are more or less on top of one another. Whereas in contrast, in the newer trials, regional node radiotherapy significantly reduced the risk of breast cancer recurrence. And the rate ratio here is 0.88, and the 15-year gain is 2.6%. And this is what happens if you look at breast cancer mortality. Again, on the left, you've got the older trials, on the right, the newer trials. And in the older trials, there's no evidence that regional node radiotherapy had any effect on breast cancer mortality. So the curves are on top of one another. Whereas in the more recent trials, regional node radiotherapy significantly reduced breast cancer mortality. Now, the other thing that's interesting to look at on this slide is the heights of the curves in the older trials on the left and the newer trials on the right. In the older trials, breast cancer mortality is way up here, and in the newer trials, it's about half. And that reflects the better survival from breast cancer nowadays. The other thing to remember is that we use better systemic therapies nowadays. And despite these improvements in breast cancer mortality and better systemic therapy, nodal radiotherapy still reduces breast cancer mortality. And the absolute gain here is 3%, and the rate ratio is 0.87. Now, this is looking at non-breast cancer mortality, again, with the older trials on the left and newer trials on the right. And in the older trials, what you see is that regional node radiotherapy significantly increased the risk of dying from non-breast cancer causes. And that's largely driven by just one of the older trials. And it was due to radiotherapy causing deaths from heart disease and from lung cancer. Whereas if you look at newer radiotherapy, there's no evidence that regional node radiotherapy increases the risk of dying from non-breast cancer causes, as we would expect based on radiation doses from modern radiotherapy. And here you can see any death. So that's a combination of breast cancer mortality and non-breast cancer mortality. And on the left, you've got the older trials. And in the older trials, radiotherapy significantly increased the risk of dying from any cause. Whereas the results in the newer trials are qualitatively different. Radiotherapy reduced the risk of any death. And the rate ratio here is 0.9, and the 15-year gain is 3.0. Now, people often ask us to look at the effects of radiotherapy in different subgroups, and this is what happens when you do that. So this is the effect of breast cancer radiotherapy. Down here is the overall rate ratio, 0.88, and it's highly statistically significant. What happens if you split that effect according to here at the top, age of entry? There's no significant variation in that rate ratio. For nodal status, again, no significant variation in the rate ratio. Neither is there for grade or for tumor size or for estrogen receptor status. If you look here down at panel F, this is the rate ratio split according to breast quadrant, and there is some borderline heterogeneity here, suggesting that internal mammary chain radiotherapy may be more effective at treating medial or central cancers compared with lateral cancers, and that fits with a prior hypothesis. And this is some more subgroup analyses split here according to breast surgery at the top. Here, nodes are radiated. This is the randomized comparisons in the different trials. So the top row here in panel H is trials that randomize women to IMC, supraclav, and axilla versus not. And then the next one is trials that randomize women to IMC versus not. And if you look at these black boxes on the right, you can see that most of the evidence in this meta-analysis includes IMC radiotherapy. But there's no significant heterogeneity in any of these rate ratios. Now, this is an illustrative calculation, and what it does is it takes the absolute rates of breast cancer mortality averaged across treatment groups, and it applies the overall rate ratio to those rates for breast cancer mortality. And so what it does is it gives you the predicted 15-year gains from regional node radiotherapy in different subgroups. So on the top row, you've got women with node negative disease, and their predicted 15-year gain is 1.6%. And then on the next row, you've got women with N1 to 3 nodes, 1 to 3 positive nodes, and their predicted 15-year gain is 2.7%. And on the bottom, you've got women with 4 or more positive nodes with a predicted 15-year gain of 4.5%. And so the overall conclusions from the meta-analysis are based really on the newer trials, because it's those that are most relevant to practice today. And in the newer trials, regional node radiotherapy significantly reduced breast cancer mortality. There was no evidence of any effect on non-breast cancer mortality, and it significantly reduced overall mortality. And the absolute mortality gains were greatest for the women with a heavily node-positive disease. And in my final slide, I'd like to thank many different people. This slide shows the EBCTCG collaborating trialists, and there are several hundred of them, and the work wouldn't have happened without them. So thank you to the trialists, thank you to our funders, and also to the 14,000 women who agreed to be randomized in the trials. So I'll leave it there, and I'm happy to take any questions. Shall I stop sharing?
Thanks, Carolyn, for the excellent overview. We could have continued the presentation for about a couple of hours. You mentioned before that there's a 50-page supplement, so we can go into any details. And let's start with the question. Everyone, please contribute and ask your question in the chat. It's important to have an interactive discussion here. Let me start with a question. What would be an explanation that the older trials did not impact recurrence outcome, but the newer ones did? Was target coverage more poor or worse? Or is the radiotherapy effect somehow related to better systemic treatments?
Yes, that's a very good question, and it's come up several times over the past few years. And actually, it's one that we deal with in the discussion section of the paper. So I'll give you a short answer now, but if you'd like more details, you can look at the discussion section. I think one reason is target coverage. Radiotherapy has improved since before the 1980s. Another reason is that many of the women in those trials didn't have chest wall radiotherapy for node-positive disease in the older trials. And what that meant is that there were lots of recurrences, and therefore the effect of regional node radiotherapy was probably lost in among all the additional chest wall recurrences.
Maybe a slightly similar question. There was more or less a one-by-one translation of the reduction of risk of recurrence to breast cancer mortality, which is rarely observed, that each recurrence also translates into cancer-specific death. Is that due to underreporting of recurrences, or is there truly a one-by-one relationship from a clinical biology perspective?
Well, one of the challenges in looking at the effects of regional node radiotherapy is that your target, the regional nodes, you tend not to get recurrences detected in those areas. And so what we saw in the meta-analysis was that radiotherapy reduced the risk of distant recurrence. It didn't do much to local recurrence. And that's probably because what it's doing is reducing regional node radiotherapy, regional node recurrences, but there are the recurrences that you just don't see. They remain undetected. And those are the recurrences that tend to result in distant disease before they give rise to any local disease. Does that make sense?
Yes. We have a couple of more questions. A question by Dan. Thanks for contributing. Is it correct to include the non-randomized Danish trials into the overall survival results, since they excluded the intramedullary Cheney radiation on the left side to spare the heart?
Oh, yes. So again, that needs some explanation, which is provided in the paper. The reason for including the Danish, well, there are several reasons for including the Danish study. The main one is that this was a Danish nationwide study, and all eligible women were included, regardless of whether they got protocol treatments, and they nearly all did get protocol treatments. And so we felt that, and the statisticians also felt that it gave a comparison of left-sided radiotherapy versus right, gave an unbiased estimate of the effects of irradiating the internal mammary chain. And so the other reason is that it's included over 3,000 women. And so it really does increase the power to detect the effects of internal mammary chain radiotherapy. So I think the first answer is it gives us an unbiased estimate of the effect of radiotherapy. And the second one is it increased the power of the analyses.
We also have a question of Galina Fischer. Thanks for contributing. If PN0 were all patients CN1.
Sorry, what's the question?
If patients were having PN0, were the patients being CN positive before surgery? No, they were not.
No, so PN0 means they're pathologically node negative at axillary surgery, and nearly all of them got axillary clearance. We had pathological node status, I think, for everybody or nearly everybody in the meta-analysis, certainly in the newer trials. So we didn't use clinical node status. Does that answer the question? I'm not sure.
I'm not sure either, but maybe you can put it in the chat, Galina. We have a couple of questions about the exact regions to be irradiated and what conclusions can be drawn. Does the analysis now support to include them all? Because in the majority of patients, the randomization was supra and internal mammaria. Is it only addressing most of the internal mammaria? What would be the interpretation of the data in this perspective?
So that's helpful. In this 50-page appendix that you mentioned, it gives you the different regions that were irradiated in the different trials. So you can use the tables near the beginning of the supplementary material. So that tells you what was done in the trials. What we can't do is use these data to tell people how extensive their nodal targets should be. What we can do is tell you what they did in those trials. But radiotherapy has moved on since those trials, and in many of them, some of them, the target wasn't contoured, for example. So I think this is something for people who are writing guidelines to look at what was done in the trials and then to use that to work out the best way ahead for modern radiotherapy. And one thing that we're doing as a part of this meta-analysis is we're going back into the trials and doing a radiation dosimetry study to show exactly what was done in those trials based on the protocols. So that will help people to know what was done in the trials.
We have another question of Professor Eich, Hans Eich. Many thanks for joining. What about the side effects plus minus radiation of the regional lymph nodes? Can you please differentiate between older and newer trials?
So what we do in EBCTCG is we get all of the available data from the trialists, and those available data concern the side effects on second cancers, lymphedema, and on mortality. But we didn't have data on some of the other side effects of regional node radiotherapy. But what we can say is that in the older trials, radiotherapy significantly increased the risk of dying from particularly lung cancer and heart disease. And that's addressed in a different EBCTCG meta-analysis that was published in 2017. Whereas in the newer trials, as we would expect, based on modern radiotherapy, there was no evidence of any effect on non-breast cancer mortality, heart disease, or second cancers. And all of that's in this big appendix. So we've got trial by trial, one line per trial plots of the effects on lots of different outcomes, including side effects.
This does not immediately address your meta-analysis, but we have two questions, so I want to state it. I mean, the question is about the neoadjuvant setting, the recent kind of publication, or at least the data being presented by the NSABP 51 trial. Can we draw any conclusions from the meta-analysis into the neoadjuvant setting? Because I don't want to ask you to address a trial which was not your own, but can we learn anything in patients having a neoadjuvant systemic therapy?
I think that's a really difficult question. The meta-analysis is about the effect in the adjuvant setting. I don't think it can tell us about the effect of regional node radiotherapy in the neoadjuvant setting. I think we need to wait for the randomized trials to answer that.
We have another question of figure 2 shows 15-year breast cancer mortality of 22 to 25%, while any recurrence at 10 years shows similar numbers, 22.9 to 25.6%. Does this mean that we are not curing most recurrences, or most recurrences are metastatic and therefore deemed uncurable?
I've just took my time to find figure 2. So figure 2A, I wonder if I
So I
can...
think it's about this more or less one-by-one relationship, which we had beginning
Yes.
between breast cancer mortality and the risk of recurrence. That more or
Yes.
less all recurrences in the end translate into a death,
I
into
think,
breast cancer death.
yeah, but it's because they're distant recurrences. So again, it's a very good question. And for example, radiotherapy after breast conserving surgery, it reduces the risk of local recurrence, and there's a ratio of 4:1, 4 local recurrences avoided for 1 breast cancer death. This is different. And I think that's because the effect of radiotherapy is on the regional nodes, and you don't see recurrences there. We collected all of the information on recurrence location, and there were hardly any recurrences detected in regional nodes because I think we just don't see them. They're there, but clinically you can't spot them, and so they turn up as distant recurrences. And I think that's where the 1:1 thing, 1 recurrence avoided, 1 breast cancer death, comes in. I've got it on my screen if you want me to share, or...
Yes, please.
Here we go. Well, this is figure 2 in the Lancet paper. Oh.
Now we're seeing the PowerPoint again.
Yeah, that was... So
yeah, it's figure 2, correct, yeah.
Yeah, this is figure 2. These are the figures that we submitted to the Lancet because I was able to get them clearer. And also, I think in terms of showing figures, it's best to show the versions we submitted rather than the published versions. So this is any recurrence on the left and breast cancer mortality on the right. And the effect on any recurrence is very similar to the effect of breast cancer mortality because most of those recurrences prevented are distant recurrences. And that's in the appendix too. We've got recurrences split according to distant and local. I'll stop sharing.
We have a couple of more questions, few more minutes to go. Question of Connie. Dear Carolyn, thank you for the presentation. I have 2 questions. The first, the EORTC internal mammaria trial was included into the internal mammaria versus not group, or as it is also irradiated the supraclav areas?
Yes.
So about the inclusion of the EORTC trial.
Yeah, the EORTC trial, again, this is in the appendix of the paper, that was IMC plus supraclav. So that comes into the IMC SCF axilla category. I had very broad categories in the table that I showed.
And the second question is, based on the subgroup analysis, would you propose, that's a proposal, regional radiotherapy for PT1, PN0, grade 1 or 2 tumor localized in the medial quadrant? So this goes into recommendations. We have talked about it before, that the meta-analysis presents data, doesn't make recommendations. But what would be your proposal in this early stage? PT1, PN0, grade 1 or 2, localized medially?
Yes, so this is it's a helpful question. What I might just do is share my screen again, because on this screen you can see national guidelines and international guidelines, hopefully.
Yes.
So we chatted about this just before this meeting. National and international guidelines vary quite substantially. So the guidelines in the UK at the top, for example, differ quite substantially from the guidelines in other places, such as the USA. This is a review that we did in 2019 of all the different guidelines for IMC radiotherapy in different places. And I think it showed quite nicely that the guidelines vary geographically according to where you are. And so I think different countries will take this evidence and work on their own guidelines. The other thing to say, I think, is that you can work out benefits and risks for individual patients. So for some individual patients, the risks are much higher than for other patients. So it might vary according to the risks and benefits of the patient in front of you.
Would you expect that the application last question of regional irradiation will increase based on the subgroup analysis that even PN0 patients had a breast cancer survival benefit, and that there was no increased risk of non-breast cancer deaths? So what would be your expectation on a systematic scale on guidelines?
I think my expectation is that IMC radiotherapy will increase. In the EBCTCG, what we tend to do is present the evidence for other people to use in creating the guidelines. I think this shows quite nicely the absolute benefits of regional node radiotherapy, and for most women, that's likely to be higher than their absolute risks.
And maybe also emphasizing one finding which you've showed on a slide but not mentioned explicitly. The biggest gain was being observed in patients and women having been exposed to endocrine therapy and chemotherapy. That was the subgroup having the largest benefit, wasn't it?
Yeah, but the problem with that is that when you split the data into different subgroups, you lose statistical power. And so I think there was no significant difference between those two. We've got to be quite careful not to push the data too far. So I've got it in front of me at the moment. Here we go, subgroup analysis here. So this is use of systemic therapy. Is this the one that you're referring to there?
Yeah.
There's the rate ratio if you split it according to systemic therapy, chemo, endocrine, etc. There's no significant difference between those boxes. So you know, I think it's just we run out of power when we split things into subgroups.
At least the kind of points went into a direction indicating that there might be a stronger benefit in women having a more effective or more intense systemic therapy. That might be the statistically correct wording.
I don't know.
Okay, with that, we're already 3 minutes past. I would like to express my deep thanks for joining us, for presenting the data, in particular for taking a deep dive into the data, discussing them, giving us some ideas how we can and how we could interpret it for implementation in our clinical practice. Many thanks, congratulations again to this fantastic contribution to our next generation design of clinical practice guidelines. Thank you very much.
Thank you for having me.
And before everyone leaves, I would like, of course, do some advertisement for our next virtual Grand Round meeting, which is, as you might expect, happening in exactly 4 weeks, 1 month, where we yet again address a very important publication which has been published just a few weeks ago, the CURB trial, a standard of care systemic therapy with or without stereotactic body radiotherapy in patients with oligoprogressive breast or non-small cell lung cancer, the CURB trial. This trial reported an overall benefit for this mixed cohort of patients having breast cancer and lung cancer in terms of progression-free survival. But there's many questions which can and should be asked. Is that true for all patients or maybe only for the lung cancer cohort? Will it translate into overall survival benefit? How do we implement that into our daily clinical practice? And I'm very happy that on the 7th of February, we are inviting and we will be joined by Jillian Tsai. She's Associate Professor at the University Health Network in Toronto and at the Princess Margaret Cancer Center. She has been PI of the trial. She's leading in Toronto the palliative radiation and oligometastatic program and also the registrars there. Join us on the 7th of February, again, between 5 and 5:30. Thanks everyone for joining. I hope this was enlightening you for breast cancer, and the next one will also be interesting. Thank you very much and see you in a couple of weeks.